I'm going to give the talk this morning on chronic pain, and it's been an evolving process. My name is David Hanscom. I'm an orthopedic spine surgeon who started practice here in Seattle in 1986, and it goes by extremely quickly. It's unbelievable. So I practiced in an era where we did 9 times the rate of spine surgery for back pain is in place in the entire country. And I was part of the whole juggernaut. So I would do clinic, then I would go to the operating room and do a lumbar fusion for back pain. We did dozens and dozens of fusions. We did 9 times the rate of spine fusions as New England back in those days. And we felt really zealous about this. We're excited about it. At L4-5, the pseudoarthrosis rate was about 40%. With the Steffi plates, we were able to get it down to about 10%. And we thought we were able to get a solid fusion that we really had back pain solved. Then in 1993, the data came out that the success rate in the state of Washington for workers' comp, the success rate for a spine fusion for back pain was 22% at 2 years. And my patients were maybe 40, 45%, but I was working really hard on rehab, and I just stopped. I stopped doing fusions for back pain, and I didn't know what to do. And I asked my partners before that, I go, what's the data on these fusions we're doing? And they go, we don't really know. So it just seemed like a good idea, but obviously it's a very invasive procedure. I still remember with remorse 2 patients in their 20s who I did fusions on dead, normal lumbar spines. No dehydration, no degeneration, nothing, but their discograms were positive. Well, since then, most of you know discography has been completely discredited. And so it's one of those things where I've been on both sides of this fence. So for about 10 years, I didn't know what to do. In the meantime, I went through my own chronic pain process in a pretty horrible way for about 15 years. In the middle of that whole process, I came out of it completely accidentally in about 2003, pure luck. And that's a different conversation. And then but I still don't know how I got into chronic pain. I didn't know how I came out. I still had no idea what happened. It took about 5 years to start to get a feel for it. In the last 5 years, neuroscience research has made it incredibly clear as far as what the problem is. So I've been excited about treating chronic pain. And when I give lectures around the country and ask people, how many of you are excited about treating chronic pain, essentially nobody raises their hand. And that's my purpose today, is I want to give you the basis of neurological basis of chronic pain. And once you understand the diagnosis, it's incredibly effective, efficient, and enjoyable. So I want to start out with a video of somewhat of a spectacular success story, unexpected at the time again. And I'd like to introduce you to a patient of mine, Mark Owens, who I met about 5 years ago.
Broke my back in 2 places and crushed my entire left chest in and punctured my lung. I had to be medevac to Kalispell Medical Center in Montana, where they fused my spine from my thoracic 9 to lumbar 2. The pain got worse and worse, and I had to take more and more opiates to control the pain. It got so bad that I couldn't stand it any longer. Who fused my lumbar 2 to my lumbar 3, everything from Norco to OxyContin, oxycodone, Ultran, muscle relaxers, sleeping aids because I couldn't sleep, and the pain wouldn't go away. You become socially isolated by your pain because people don't want to see you suffer like that. Pain that probably went from 7 to 10 all the time. At times it was so bad I couldn't stand it. I would just, frankly, I got to a point where I wanted to die. It was, wow. Well, finally I went to a surgeon in Spokane, Washington, and he breezed into the room and said he'd looked at my charts and everything, and the only thing that was going to do me any good was what he called the blue plate special. He said, it's going to take 2 surgeries, it'll take probably at least a full day and probably 2 days, and we're going to break your back in 2 places. We're going to clean out all the stenoses in your spinal canal and in your nerve root canals, and on and on and on. And he said, in the end, he said, we're going to fuse you from your collarbone to your hips. And I said, but I won't, well, you know, he said, it's not a good option, but he said, it's the only one that'll work for you. Your back's a mess. I need another opinion. And so I got an appointment with a Dr. David Hanscom at Swedish Medical and in Seattle, and went to see him. He said, I see nothing in your spine that would cause the pain you're feeling. It's like the phantom limb syndrome. People who have amputees often feel the same pain after after a limb that is giving them pain is amputated as they did before they lost the limb. And it's, again, the rewiring of the brain. He said, what I'm pioneering along with some other physicians, a program that will provide an alternative to having that more spinal fusions. And he explained that only around 15 to 30% at the most of spinal surgery fusions are ever successful in alleviating pain, even over the near term, let alone the long term. And so he said, I would like you to try my program. I said, well, what does it consist of? And he said, well, the first thing you can do is read my book on the subject. But he said, immediately you can start what we call expressive writing. And I said, well, what is that? And he said, well, you sit down and 15 minutes in the morning, 15 minutes at night, and you write down every negative thought you have about anything in longhand, and you tear it up and you throw it away. And I said, what? First of all, I said, that sounds like snake oil. I was really honest with it. I said, I'm a career scientist, and I'm taught to be a critical thinker, and I'm by nature skeptical anyway, so I frankly think this sounds like snake oil. And he said, well, you can think what you want, he said politely, but he said you can always be filleted like a salmon. And he said there'll be plenty of surgeons who'll do that, but I won't. And he said, or you can try this technique and the whole program eventually. I said to my friend again, this really sounds unbelievable. And I said, like the doctor said, I can always be filleted, I'll just try it. So we drove down the coast from Seattle and stayed in a motel that night. And that night I actually did some of this so-called creative writing. And I woke up the next morning, and the pain I was feeling, and maybe I should back up a little. When you live with pain like this, it's like you have a leech attached to your body or a monkey on your back that you can't get rid of. It's always there. You're always thinking about it. You don't realize, but it preoccupies every aspect of your being. I woke up that morning after doing this first session of creative writing, and the first thing I noticed is that I didn't have that monkey on my back, that leech. And I didn't even, first, I'd forgotten I'd even done the negative writing or the creative writing the night before. And I thought, what's going on here? You know, this is great. It still hurts, but it's nothing like it was. Make the long story short, and after another 24 hours, I was 85% pain-free. 85% pain-free. And today, 3 years later, more or less, I have pain, but it's pain that's easily controllable with a Tylenol. And sometimes I'll go through 3 weeks or more without even taking a Tylenol. And I'm living a reasonably normal life, a fairly active life, riding horses, chainsawing, cutting wood, doing physical things. And they do make my back uncomfortable, but I don't have this debilitating, crippling pain. Basically, by visiting Dr. Hanscom, I got my life back. broke my back in 2 places and crushed my entire left chest in and punctured my lung. I had to be medical.
So Mark's story is not an uncommon story, and what's a little uncommon about it is how fast it happened. But I would say yesterday in clinic, last 2 days in clinic, we had 4 patients with stories very similar to Mark's. One lady, fibromyalgia for 10 years. She came in pain-free after about 4 weeks of doing the process of just relaxation tools, et cetera. And another gentleman, 5 years chronic pain, same thing. Another workers' comp patient who is a more difficult population to treat, same thing, pain way, way down, very excited about it, going through a whole rehab process. And it's been consistent, and if somebody engages with just the basic tools and the structure, why probably within 3 to 6 months, probably 90% of people go to pain-free. So it's not about managing the pain, it's about people really resolve their pain. Now there's one point I'm gonna say about 5 times today, so I want you to remember one thing out of this lecture. This is it. This is about anxiety. Anxiety is the pain. And anxiety is not primarily a psychological issue. So anxiety is that sensation generated by stress chemicals. When your body's full of adrenaline, cortisol, other stress chemicals, your body feels anxious. So anxiety is a result of sensory input, it's not the cause. Okay? The reason why it's so critical is that the unconscious brain, the survival response, is about 1,000,000 times stronger than the conscious brain. I mean, I'm not coordinating my muscles consciously, my mouth is moving automatically, my pupils are dilating, that's all the unconscious brain. So anxiety, essentially every second of your life, every living creature is controlled by avoiding things that cause anxiety. The creatures that didn't pay attention to the cues didn't survive. Since it's essentially a survival response, we all hate that feeling. We act as quickly as possible to solve the problem, creating the anxiety. So that's the key to this whole lecture, is that looking at a neurochemical response to the environment that's not subject to rational control. So this situation is, I mentioned earlier, I was in chronic pain myself for 15 years. I worked super hard. I had a tough childhood, but medical school, college, residency had a great time. Then at 38 years old, I started having panic attacks. So I didn't even know what anxiety was. So I went to a very high-level spine fellowship in Minneapolis. I didn't get there by having anxiety. So my thing was bring it on. I mean, I honestly had no clue I had anxiety. In fact, when I was 20 years old in Hawaii, I had an orthopedic patient come in with an anxiety disorder, and I'm going, what's that? I had no idea. And I had to go to Harrison's textbooks of medicine and look up the word anxiety. But what I didn't realize at the time is that this drive to escape anxiety was so strong that I didn't actually feel it. But the same drive that took me up the hill took me right down the other side. So even though I didn't feel anxiety, I was having migraine headaches, my ears were ringing, my feet were burning, I had some neck issues, back issues, but just bring it on. I didn't actually feel anxiety. I was driving across the 520 bridge in 1990 after a Puget Sound Spine Interest Group meeting, and I had a panic attack. So I went from no anxiety to a panic attack. So even now, as I talk about it, how can that be? So even though I didn't feel anxiety, my body didn't believe me. And the problem is, when you're stressed, your body chemistry is going 1,000 miles an hour or more. You get physical symptoms, but you may not feel anxiety. So none of us like it, so we suppress it, but your body doesn't believe it. So it was by accident, I picked up this book called Feeling Good by David Burns, and I started to write, and I thought it was the book. It turned out to be the writing. There's now over 1,000 research papers that document that expressive writing helps chronic pain. So here's a woman, Esty, who I met about 4 years ago at Omega Institute in New York. She'd been in chronic pain for 4 years, 10 doctors, 6 injections. Within 1 week, she was pain-free. She just got married about a year ago, has a baby, husband, no narcotics, no pain. Rita, she's the record holder. 55 years of chronic pain. She's been pain-free now for 4 years. What the doctors didn't ask her at age 40 is that her husband committed suicide, and then 4 years later, her son committed suicide. Nobody asked that question. So 55 years of chronic pain, she's been pain-free for 4 years. This is Mark Owens, who you just heard. Holly, 10 years of chronic pain. Headaches, stomach pain, right leg pain, vaginal bleeding, and she, within 2 weeks, went to pain-free. The key for her was that she had had a stillbirth. Her obstetrician told her that her womb was, quote, inadequate. Total guilt, total frustration. She never got to hold the baby before the baby was buried. And within 3 days after figuring this out, she was pain-free. 4 years later, she just got engaged, and she's doing fine. So what's going on? So all those people have been in the medical system for anywhere from 4 to 40 years, all sorts of medical treatment, and within weeks they were pain-free. What happened? So I look at the nervous system. First of all, I think medicine's done a huge disservice by separating the mind versus the body. So we're just a unit. I mean, think about trying to fly a Boeing 747 airplane without a computer. You can't do it. How do you have an orchestra without a conductor? How do you have a conductor without an orchestra? So basically, we are a unit. This is a unit response. The cell bodies happen to live in the brain, in the skull, but basically this is a unit. Each square inch of your body has 1 million pain fibers per square inch. So we're just enmeshed in neurological tissue, and we're a trillion times more complicated or more than a Boeing airplane. So your nervous system is basically a unit response. So what's happening is that you're processing sight, sound, touch, taste, feel. Again, every living creature has an anxiety reaction to a threat. So a physical threat is going to create a summation and give you a chemical surge. So if the input is pleasant, you'll get oxytocin, dopamine, the GABA drugs like Valium, et cetera. And most of the time, the nociceptive system, by the way, keeps us in a neutral zone. In other words, I'm not staring at that light. I'm not sitting on hot surfaces. So your unconscious brain keeps you actually within a range that's safe. So the nociceptive system, by the way, is backwards. So the nociceptive system keeps you out of pain. When you feel pain, you've actually exceeded the limits. Now, if the sum total is unpleasant, you have adrenaline, cortisol, and endorphins, and lots of other stress drugs, and then you have the chemical surge, then you feel anxiety. When you have the chemical surge of the other drugs, you feel relaxed, right? So the problem that humans have is that we have thoughts that actually create the same chemical reaction. So the problem is that we have 4 things that are a problem. So there's a great paper in 2013 by Dr. Smythe out of Pennsylvania that showed that there's acute stress is defined as any chemical reaction with the environment that abates when the threat is gone. Anything more than that is chronic stress. So there's 3 kinds of chronic stress. There's repeated activations, which all of us have, but especially in the workers' comp system. And you have people who don't adapt very well. In other words, they have a stress, they have a delayed reaction to back to normal. Then some people never go back to normal. They just stay in this agitated state to the environment. Okay, so your body's full of stress chemicals, but that doesn't even count the fact that thought creates the same reaction. So in addition to the physical threats, humans have thoughts. I call it the curse of consciousness. So you can't escape your thoughts. We suffer with them. We can mask them, different type of addictions, et cetera. Or what, I think what physicians do or professionals do in general is we suppress. So whether you suffer, mask, or suppress your thoughts, you have a problem. So what you end up with is a sustained chemical response. And unfortunately, with the fellows and residents that come into the program, you go back to the repeated activations. Most of us are trained by repeated criticism. Okay, that's somehow going to motivate us to do better, right? Well, people who actually thrive in a safe, nurturing environment, they actually don't thrive in a very adversarial environment. So the bottom line is you have stress chemicals on a regular basis, you're adrenalized, you're sort of active, but eventually that burns out. Right now, the burnout rate in medicine is about 65%. That's a lot. So what do you do? So most of us, the thoughts become quite real and we react. So you have this sustained chemical reaction of your stress hormones. Your body starts developing physical symptoms. And if I took a survey, there's over 30 symptoms of a stressed out nervous system. And some people are like this. They have these different thoughts floating around. They don't actually take them too seriously. But I'm not sure what % of people do that. I don't do that. So again, reviewing, anxiety is that feeling generated by stress chemicals. End of story. So the logical way to have less anxiety is not to analyze it and fix it. Remember, it's a 1,000,000 to 1 ratio. The logical choice is to decrease the adrenaline, right? So as you decrease the adrenaline, decrease that stress response, you start feeling less anxiety. Am I still on there? Yeah. So there's an article out of Chicago, 2014, which documents a very interesting problem. This was with chronic back pain versus acute. So they took and did research MRI scans or functional MRI scans on volunteers who had pain less than 3 months, back pain. And they found out, of course, that the pain center lit up. Then they did the MRI scans on people who had pain more than 10 years. The pain center was dormant, no activity at all, only the emotional center lit up. In other words, you had the same back pain, but a different driver. Then they took the acute patients, about half of those volunteered to have their scans done serially. And what they found out is that the people that became chronic shifted to the emotional center within 12 months. And the ones who resolved their pain, everything went quiet. Then they used the reward center as a control, which stayed the same. So basically, your pain shifts to a different part of the brain, but you have the same output. Then what happens, this pain, this way the nervous system works, the neuroscientists have a little saying called neurons that fire together, wire together, is that these pain sensations get connected with more and more life experiences. So you're playing tennis, you hurt, playing the piano, going to a party, whatever it is, this pain starts occupying your life. So right now, the definition of chronic pain is that it's an embedded memory that becomes linked with more and more life experiences, and the memory can't be erased. Okay, so the pain's in the emotional part of the brain. You've got more and more life experiences connected with it. And the more you try to erase it, the more attention you pay to it. But remember, again, this is part of the unconscious brain, not the conscious brain. So they're permanent. So it's like riding a bicycle. Once you know how to ride a bicycle, you actually can't really unlearn how to ride a bicycle. It's a permanent pathway. So we can't really unlearn how to walk unless we have some type of neurological problem. But once you have your brain programmed with stuff like riding bicycles, talking, et cetera, those are permanent pathways. Your anxiety response to stress is a permanent pathway. You're not getting rid of it. So we all know about phantom limb pain. And ever since medical school, I do orthopedics and have done plenty of amputations. And I remember even as a medical student going, this is crazy. I mean, nobody's really, I don't think, back in medical school, paying enough attention to that whole process that you have an amputation and the limb still hurts. And the data that I saw is about, and the dealing data on this, Tim, is about 55%. So they not only feel the leg, they feel the same pain they had before the amputation, but they can't touch it. You can't massage it, you can't distract yourself. So these people really go crazy. So then you're trapped. You're trapped by the pain, you're trapped by your thoughts, you're trapped by circumstances, trapped by relationships, money, whatever it is. So you're trapped. So, right, what would happen to your anxiety if you put your hand over a hot stove? Okay. And what would happen if I grabbed your hand and forced you to hold it over the stove? Right, so the next impulse would be anger. Everybody's such a nice guy, he definitely would not fight back. Actually, he went on our ski trip a couple years ago and he would fight back, trust me. So what happens when you're trapped by anything, your body kicks in more adrenaline and cortisol to solve the problem. So basically anxiety and anger are the same thing. So what happens is, can we turn that microphone down back there? So basically anxiety and anger are the same thing. Basically, as you have anxiety, you try to take evasive action, you can't, your body kicks in more stress chemicals from an evolutionary standpoint to solve the problem. So when you're trapped by anything, whether it's perceived or real, your body's gonna be full of stress chemicals. So what happens is the adrenaline. So there's over 30, so it turns out that actually in humans, that the mental pain or the mental threat is a bigger problem than the physical threat because you can't escape it. The problem is that mental threat sustained, it translates into chemical changes, which translates into physical symptoms. There's over 30 symptoms of a sustained adrenaline response. So at the time I was going through this process, I had 16 of them. So I had migraine headaches, tension headaches, shoulder pain, back pain, my feet were burning, these skin rashes would pop up, I couldn't sleep, extreme anxiety, just went on and on and on. I had no idea. And of course I saw all sorts of medical care, lots of doctors, EMGs, medications, you name it, nothing worked. So then the anxiety became extreme. And one thing, by the way, that physicians have, that's a problem, especially surgeons, is that we're a perfectionist. So we have this idea of what perfect is. We're not going to reach that. So you have a chronic anxiety, right? You're trapped by being less than perfect. It's a big problem. So we have these adrenalized nervous systems, and these physical symptoms take place. So it turns out that the mental pain, again, not psychological. This is not a psychological situation. It's a 1,000,000 to 1 ratio. You can't solve this psychologically. So what happens if you start doing, what medicine's doing right now is that we're throwing structural solutions at a neurological issue. And I don't know if the term neurological is correct. It's an embedded set of circuits that are permanent, that are stimulating your body in a big way. So it's not really a neurological disease, but it's a neurological situation. So if you start doing structural interventions for fired up nervous systems, it's a problem, right? Now, just to sound a little cynical, is that essentially every intervention we do in spine surgery or spine care doesn't work. So we know epidurals for axial back pain doesn't work. We know that facet rhizotomies work about half the time. We know opioids don't work. We know back fusions for back pain, 20% success rate. So right now, medicine won't cover behavioral health, which is different than psychology, by the way. So the solution we'll talk about maybe in a different lecture. We're not going to talk about it today, but I really want you to understand that this is a, I think, basic concept that's being documented very hard in the neuroscience literature the last 5 years. It hasn't penetrated mainstream medicine. It just hasn't. So when you start doing structural interventions for this neurological situation, it's not going to work, and it doesn't work. So if you go to the dentist with a tooth that's painful, whatever, and you have the tooth pulled or repaired, it works, right? But if you go to the dentist with mouth pain, and you don't know where the pain's coming from, and you start doing procedures, that's not going to work, right? Or it might work, but probably not. So with back surgery, for instance, the data used to be 15%. It's now down to 5% that we know where back pain comes from 5% of the time. Yeah, there's over 400,000 fusions done right now for back pain. There's a success rate of about 20%. Which even worse, which I didn't know this until a couple years ago, but this data's been out for a while, that if you perform any procedure, the presence of ongoing chronic pain, you can induce chronic pain at the new surgical site up to 40% of the time. Actually higher some places. So let's say you have chronic neck pain and you have a hernia repair, which is pretty simple, usually relatively painless. You can induce pain at the hernia site. That one is 5 to 60% of the time. In a small percent of the time, 5 to 10% of the time, that becomes permanent. So if I had a neurological complication rate of 5 to 10%, I mean, how long would I stay in business? Tim's going to tell you I actually have the complication rate, right? He's my competition. But no, I mean, you can't have neurological complications at that rate and stay in business. Chronic pain is probably worse. So they estimate that the impact of chronic pain on a person's life is worse than terminal cancer, or equivalent to terminal cancer. The average lifespan of someone in chronic pain is 7 years less than the population. We know that people in chronic pain or chronic stress have higher heart disease, depression, anxiety, autoimmune disorders, and the list is about 50 long of stress-related disorders, including a higher mortality rate. There's a paper came out of Sweden 2 weeks ago on over 330,000 patients. They have a national registry linking chronic stress to autoimmune disorders. And we've been suspicious of that for a long time, but the data is right there. So when you start doing surgery, that's why we now do this prehab process, that if you don't calm down the nervous system first and go ahead and do an invasive procedure, you're going to induce chronic pain at the new site, not the old site. So right now, there's also a paper out of Baltimore that shows that only 10% of spine surgeons are actually acknowledging the known risk factors for poor outcomes before they do the surgery. I won't ask for a show of hands, but it's pretty common for surgeons to want imaging done before the patient sees them so they can make a surgical decision on the first visit. Anybody know? Right, very common. So we don't make surgical decisions ever on the first visit. Maybe 1 out of 50 is emergency. But in general, you have to know the patient. So what's been stunning for us is that we now have 100 surgical patients, tight stenosis, leg pain, radiculopathy, neurogenic claudication, is that those bone spurs have been there for a long time, but the pain is new. So what changed? So what's becoming increasingly clear is that situational stress changes the body chemistry, and that bone spur will be the first thing to light up. So we had a patient a few days ago who, nice lady, middle-aged, very quiet, and I talked to her for a bit, total body pain. So Angela went in and says, "You're not gonna believe this." And I go, "What?" And she said, "Well, her daughter's pregnant," which sounds good, except her husband was the father. Okay, that's stress. And another gentleman who had neck pain, and I think Peter was my fellow at the time, he said, "Look, this is not very hard. Just ask the question, what's going on?" Turns out this guy's grandson has shot his son. We have endless stories like that. We had a gentleman yesterday who been in chronic pain for 6 or 7 years, a very tumultuous relationship with his girlfriend. So his girlfriend proposed to him 2 weeks ago, and he accepted. A week ago, she committed suicide. He was not in good shape. So you have to find out who these people are. And in medicine, we're so geared towards structural interventions. We're not acknowledging the nervous system. We're not acknowledging the stress. You've got to calm down the nervous system first. So this data, 10%. 10% of people are actually acknowledging the risk factors for poor outcomes before they perform surgery. This is just one paper that actually sealed the deal for me out of Stanford. Eugene Carrigy, well-known orthopedic surgeon, did a very careful 5-year prospective study. He found out that the success rate of a fusion based on discography was 22%. I have yet to see one paper that shows that back pain actually, that spine surgery actually works for back pain. The only paper is 2001, where Fritzell, who's a surgical study sponsored by Johnson & Johnson, by the way, where they looked at 3 prospective groups. They were simply trying to determine what kind of fusion was the best fusion. The control group was just no surgery, but there's no treatment. So the surgical success rate was about 25%. The non-operative group was about 7%, which you'd expect. I mean, nobody actually dealt with chronic pain in a systematic way, so that's the only paper that justifies spine fusions for back pain. That's it. So they estimate by 2020, there's gonna be over 1 million spine fusions a year in the United States alone, over 1 million. It's now over a $13 billion a year industry. So what's going on is this. So you saw the successes, probably cost maybe $2,000 average till those people go pain-free. This is a gentleman who's my record holder. He started out with an L4-5 discectomy, worst comp, back 30 years ago. Then he had a fusion, then that broke down, then he had infection, extended it up, broke down again. He's had 29 surgeries in 28 years, okay? So what's the cost of that? Probably $5 million or more, okay? That's a lot of conservative care. So this is his last construct done back in New York. Dr. Larry Lenke did this one. I did about 6 of his operations, and I finally gave up. And he kept going back into kyphosis, but this is his final construct. He's on suppressive antibiotics. That's about 4 years ago, and he's now doing reasonably well, but he spent 30 years having spine surgery after spine surgery after spine surgery. That's not a great life. Here's Mark Owens' films, and I'm just going to talk about this for a second. So he had recommended by 3 different surgeons to go T2 to the pelvis, okay? So we know right here, he had 3, 4, 4, 5, 5, 1, has some degeneration. The data clearly shows that there's no connection between disc degeneration and back pain. 0. We know that. So then they're actually going to do an osteotomy of his fusion because now there's a huge deal in the country to correct sagittal alignment. So if somebody's like 10 degrees forward, well, when you do this huge osteotomy to get them that 10 degrees back, that makes no sense. So we have all sorts of people we prehab just by stretching out their hips. So with Mark, it was pretty simple. There's nothing to do. There's nothing on this spine that would put one flicker of mode to actually do surgery on this guy, but 3 surgeons told him T2 to the pelvis. So the Spokane surgery called the Blue Paste Special, and Mark will tell you otherwise, tell you another conversation, that the kind of, he's enthusiastic, he was selling it, this is the way to go. So he almost signed up there on the spot. And you saw his outcome without surgery. So this is a woman who, in 1990, had a 2-level fusion, L4 to the sacrum, ongoing back pain, and then she had an extension to L3, and for whatever reasons, she went right over the top, and she came in now 20 years later looking like that. Okay, so back pain surgery doesn't work. So it's exceptional maybe 20% of the time. You have double the chance of making people worse after the surgery, just inducing chronic pain either inducing chronic pain at a different site or at the same site. So you have double the chance of making somebody worse than you do getting them better. There's an 18% take back to the OR within the first year. Then you have stuff like this, and you saw her pain pump. So I'm not going to tell her whole story. It's a huge story. We actually got her back functioning, walking with some major surgeries, but it took about 2 years to get her back, and we did it. But so what a great surgeon I am, what a good guy. But 20 years of the prime of her life, raising kids with a spine like this. So we're not helping people doing surgeries that don't work. So in summary, I want to talk about that. You have this chronically stressed out nervous system, and if you count sustained anxiety as chronic pain, which I do, the mental pain to me is more important than the physical pain because you have the sustained chemical response. It's 1 million times stronger than the conscious brain, and you can have over 30 physical symptoms that occur because of the sustained chemical response. Since it's a 1,000,000-to-1 ratio, it is, in medicine we say, well, I don't see a problem, send it off to a psychologist. It's not a psychological issue. Now, psychology can help, but for instance, this expressive writing exercise. There's now over 1,000 research papers, over 1,000, that says that it works. 1,000. So I'm actually having dinner with Dr. Pennebaker, who's the original author, out of Austin, Texas, in about 2 weeks. And I also talked to Joshua Smythe, who is his co-author, and the writing research still goes. And I think one of the problems with this simple writing exercise is that they come to me for big-time spine surgery, and I'm telling them to go home and write. It's like I'm not validating their pain. It's like it's just, they want to be validated. This is sort of the opposite process. So what's the risk? 0. What's the effectiveness? High. And if somebody doesn't want to do that, in other words, you have an angry patient that says, don't, just fix me, there's exactly the person that you don't want to do surgery on. Then right now with the business of medicine, I could go on for a long time with this, we're recommending procedures that don't work. We're not talking to the patients. We're not listening. Another caveat is that lack of sleep. There's a study out of Israel, and over 1,200 patients on a 4-year prospective study that showed lack of sleep induced chronic pain. It was a cause of chronic pain. So how many of us in the room, including me, historically, to actually ask about sleep? Not really, not so much. So anyway, it's a solvable problem, and my wish for you is that we enjoy it. We enjoy treating chronic pain. There's nothing more rewarding to see somebody who has no hope, they've been bounced around, they're completely discouraged, their families are falling apart, they're out of the workforce, they're just drifting. You understand this process. It doesn't take much time to do it. We were talking about this yesterday, these 4 people that we saw, I mean, they're back out of pain after years and years of pain. I probably spent at the most maybe a half an hour with each of them. And Andrew maybe spent a little bit more time with them and Sarah Jane, but it doesn't take much time. Because if they don't want to own it, you can't help them. If they own it, they start taking off. So there's another paper of Australia that points out that they took a group of pain patients who they simply did 3 group sessions to educate them about chronic pain. 12 months later, the pain was down by 80% in all of them, just understanding the problem. So education, sleep, stress management, medication adjustment, they take control. It's a very, very solvable problem. Thank you.